Good morning, everybody. I am Abdulaziz Al Yami, respiratory therapist at Johns Hopkins Healthcare Center. And today I will talk about obesity from the point of respiratory. So when I say obesity and the point of respiratory, that's mean obesity and obstructive sleep apnea. And we're going to go over what is obstructive sleep apnea and what is the relation between obesity and obstructive sleep apnea. The objectives that I'm going to go over are obstructive sleep apnea definition, obesity impact on upper airway system, relation between obesity and OSA, which is obstructive sleep apnea, OSA diagnosis, and obstructive sleep apnea treatment. So that the beginning, let's know what is OSA or what is obstructive sleep apnea. So it is a cessation or significant reduction in airflow in the presence of breathing effort. So it is a reduction in the air movement during sleeping, which causes a significant reduction in airflow, and sometimes completely there is no air movement during sleeping, or there is no effort of breathing, which will causes an arousal or a stop of breathing. Obesity and upper airway systems. So what is the effects of obesity and upper airway system? Obesity as a risk factor for OSA structural factors includes obese people have extrinsic narrowing of area surrounding collapsible area of the pharynx. This is factor number one. Number two, there is an increase of fat deposition in the posterior lateral to oropharyngeal airspace at a level of soft palate. So both of these two factors associated with obesity. Those two factors causes cessation of breathing, or sometimes causes reduction of air movement during sleep, which would cause apnea or hypopnea. So if you want to zoom into this figure, you're going to find that figure number one, there is a smooth air movement during sleep. And if you go to figure number two, you're going to find there is a partial obstruction of the airway, especially upper airway, which causes a reduction of air movement during sleep. And if you go to a picture of number three, there is a complete obstruction of the airway during sleep, which will cause complete reduction or complete obstruction of air during sleep. So the literature have shown that the bond relationship between obesity and OSA, and I have found some studies that say that approve that the strong bond between obesity and OSA. So study number one, a 10% increase in weight was associated with 6-fold increase in risk of OSA. So if you gain weight 10%. If you're gaining a weight at 10%, that associated with the 6-fold increased risk of OSA, and this is a good proof of the relation between obesity and obstructive sleep apnea. Another study says that moderate to severe OSA was present in 11% of male who were normally weight, but 21%. There is an association between obstructive sleep apnea in 21% of those people who were overweight, the BMI 25 to 30, and the association between obesity and OSA, there is a 63% significance of those people. They're gonna have an OSA if their body mass index is greater than 30 kg 30 kg. So if you compare it, there's a significant increasement in the risk of OSA with a BMI greater than 30. Similarly, in female, OSA was present in 3% of patients who were normally weight. So as long as you go down with your weight, as less as you're gonna get OSA. And there is a 9% of those who were overweight and 22% of those who were obese. So as long as there is an increase in body mass index, there is a high risk of having OSA. And the prevalence of OSA in male, twice the prevalence of OSA in female. And the prevalence of OSAs is common in the mid ages. So if you want to go of this algorithm, says obesity-induced apnea and hypopnea syndrome. So we started with obesity. So if the patient is obese, this obesity might cause abnormal breathing events during sleep, including apnea or hypopnea. So apnea is a cessation of breathing. Hypopnea is decrease of respiratory rate. And apnea and hypopnea, they both causes oxygen desaturations and arousals at the same time. So if the patient has multiple events of oxygen desaturation and arousals, this will affect his daytime sleepiness or nighttime sleepiness. So patient will not have enough or good quality of sleep during the nighttime, and the patient will tend to sleep more and more during daytime. How we can diagnose obstructive sleep apnea? We have three elements. Number one, clinical manifestations. Number two, physical examination. And number three, which is the most sensitive one, is polysomnography, which is sleep study. So clinical manifestation, I divide clinical manifestations into nighttime and daytime. So during the nighttime, you're going to hear snoring. Most of the obese patient, once they sleep, you're going to hear snoring. What does that tell you? Snoring is a sign of partially obstruction of the airway, especially upper airway. And if the patient snores, he might have obstructive sleep apnea. So snoring, number one. Number two, witnesses apnea, frequent nocturnal awakings, because whenever the patient has apnea during sleeping, that means he's going to have reduction of his oxygen saturation. Then the patient will going to arouse to take a deep breath again. So this frequent arousals are common with a patient who are obese during sleep due to obstructive sleep apnea. Waking up, choking or gasping because there is a cessation of breathing for like 10 minutes. Then after this 10 seconds, then after this 10 seconds, the patient will wake up choking, gasping because he felt that he was choking because of this upper airway obstructions. Then he's gonna sleep again and he might have another episode of obstructive sleep apnea. So all of these factors will affect the sleep quality during the night. And refreshed sleep and dry mouth. Dry mouth because the patient is trying to take a breath and the mouth is open. This will cause a dry mouth. And refreshed sleep because the patient he thinks that he's sleeping very well, but actually during sleeping time, this patient, he had many times of arousal and awakings. So he did not sleep very well for consecutive hours. There is a frequent awakings and there is a frequent arousals during sleep that will affect his sleep cycles and his sleep quality. If you go to clinical manifestation during daytimes, actually all of them are consequences of nighttime manifestations, because all the factors of sleeping, awaking during the sleep, due to obstructive sleep apnea, it will affect the patient daytime. Why? Because patient will have early morning headache because he did not sleep very well during the night because of this frequent arousals and frequent episodes of obstructive sleep apnea. Fatigue because again he did not sleep very well. He has very poor sleep quality. Daytime sleepiness because he did not sleep very well during the night, so he trying to compensate during the daytime. So this patient feels always sleepy during the daytime. Poor memory, concentration, or motivation. That's because of like for a long time this patient he has this episode of sleep apnea for like many years. It will affect his sleep quality. It will affect his quality of his sleeps, and this could cause an effect also on his memory, concentration, and also motivation as well. Falling to sleep during driving because again he did not sleep very well because of this frequent OSAs, and depression. So if the patient has OSA, we're going to do physical examination. One of them is obesity. So if the patient is obese, as I mentioned, based on the literature and based on the clinical signs symptoms, obesity has high association with OSA. Neck circumference, because if the patient has wide neck circumference, this might cause also OSA during sleeping. The most golden test to evaluate either this patient has sleep apnea or not is polysomnography, which is a sleep study. Polysomnography, also called sleep study, is a comprehensive test used to diagnose sleep disorders. And polysomnography records brain waves, oxygen level in blood, heart rate, breathing, as well as eye and leg movement during sleep. So we ask the patient to come to our lab. We hook all of these electrodes in his brain, chest, fingers, everything. We monitor his brain activity, we monitor his chest movement, we monitor his airflow movement in the nose, everything. Because you want to record and you want to witness the episode of apnea or hypopnea. So this test, it has to be done in the hospitals and the centers, and it has to be done at the night time, and we need to monitor the patient continuously and closely during sleep so we can figure out how many arousals the patient had. Sleep study results associated with obesity based on apnea and hypopnea index. This is an index that we use to measure how many apneas that this patient have during his sleep. The severity of OSA is classified as the following: none or minimal if the apnea and hypopnea index 5 times per hour. So if the patient has 5 times per hour apnea or hypopnea events, this is a none or minimal. Mild if the apnea and hypopnea index between 5 or equal 5 to 15 times per hour. So if the sleep study shows that this patient has 5 to 15 times events of apnea or hypopnea, we consider this one as a mild OSA. Moderate OSA if the index falls between 15 to 30 per hour. So if the patient has 15 to 30 per hour events of apnea or hypopnea, this patient is in moderate OSA, and this is significant. And if the patient has the index equal or greater 30 per hour, that this patient has severe obstructive sleep apnea, and this is a significant things need to be treated. This is a test of the sleep study, and as you can see, there is a stopping. This is a flow of air. We measure the flow in the nose, so there is a stop of a breathing, as you can see here. This is what we call obstructive sleep apnea, and at the same time there is a movement in the chest. So the patient is trying to take a breath, but there is an obstruction in the upper airway. So all of this effort during the sleep will not cause any breathing because there is no air movement to the lungs due to upper airway obstruction. So after this, for 10 seconds, then this, what we call it arousal, here the patient wakes up to take a breath again, then he's gonna fall to sleep again. So those arousals will affect sleep quality, and it will affect patient activity during the daytime. So what is the treatment of OSA? Nasal CPAP is the initial treatment. So initial treatment is we give the patient nasal CPAP. This CPAP will give the patient a constant pressure to keep the upper airway open. Because, as I said, there is an obstruction in the upper airway due to obesity, which will cause obstructive sleep apnea. So if you give the patient a constant pressure through his nose, this constant pressure will keep the airway patent and open. So this patient, by this way, we're going to reduce the incidence of apnea, or sometimes we're going to have no apneas at all. But the problem with this treatment is the patient's tolerance. Some of the patients, they cannot sleep with a mask on their nose or on their mouth or the pillows on their nose. So they cannot tolerate sleep this mask, or they cannot tolerate even the pressure, because it's a positive pressure. So it's patient's tolerance is one of the limitation of using nasal CPAP as an initial treatment of OSA. But if we're gonna go to another treatment, which is weight reduction. So if you know the reason why this patient has OSA, it was because of obesity. So if the patient gets rid of his obesity, he will not have any OSA. Weight reduction strategies appear important for an optimal outcome. So the best optimal outcomes to not having an OSA or hypopnea during sleeping is to reduce weight. You initiate your patient, you encourage your patient to lose weight, and as long as the patient will lose weight, he will not have obstructive sleep apnea, and he will have a good quality of sleep during the night. that was all about OSA and obesity, and I hope you guys get benefit out of it. Thank you.